Okay, now we are recording and I will load up those slides for you. Okay, the pelvic floor across the lifespan. So I'm very excited to talk about this because we spend a lot of time at Blueberry Therapy learning about pelvic floor stuff so that we can communicate it to you. And even just among all the therapists that deal with pelvic floor, we share lots of, what have you done and what can you do with a client like this? So we have lots of dialogue at work. And 2 weekends ago, I was in Amsterdam learning about the pelvic floor. Let me clarify, I was in my bed on my computer in Amsterdam, attending a conference. It was many international urogynecologists and physios, and got some great new information that I'll be able to share with you today on this presentation. Okay, so I know lots of you have joined one or other of my talks previously, but just as a quick refresher about what the pelvic floor is and where it is, we'll go through a couple of quick diagrams. So the pelvic floor is that nice broad group of muscles that run from the pubic bone at the front, sweeping back to the tailbone and out to either of your sit bones. So as you sit there on your chair, if you kind of shimmy side to side, you can feel the sit bones and your pelvic floor runs right across. It has numerous functions, which we'll go over in a minute. And many of those functions help support day-to-day type things. So the first one is it has a really nice, strong support function. That support function means that it helps support the pelvis as a whole. And I have my handy dandy pelvis. If you can see me. So if I'm orienting you to this pelvis, the pubic symphysis at the front here, the sit bones that I was just talking about here, and the tailbone there. Because it holds kind of together the bottom of the pelvis, it's beautifully named because it's the floor of that pelvic cavity, and it helps support many of those joints, including the pubic symphysis, the sacroiliac joint. It helps support the bottom of the core, our low back, all kinds of good stuff like that. And then it also has a large function in supporting the 3 pelvic organs in females. So the bladder at the front, and then the uterus, and then the rectum. And making sure that that muscle is nice and strong, is able to both lengthen and be strong, is important. And we'll talk about that a little bit later when it comes to pelvic organ prolapse. So that's one of its major functions, is that support function. It has a sphincter function, and that sphincter includes the urethral sphincter at the front. So making sure that when we cough, jump, sneeze, or pass a bathroom, that urethral sphincter clamps at the front, helps to keep us from leaking urine. And at the back, the external anal sphincter is equally important to keep us continent, gas, poop, mucus, anything coming out the back. And then last but certainly not least is the pelvic floor has a sexual function. We have many nerves that are more external in the clitoral area, clitoral hood. And the pelvic floor itself, when it lengthens appropriately, then typically we don't find that that we don't have pain with penetration. And both in men and women, we want that pelvic floor to be able to contract quickly and rhythmically, and that helps with orgasms. So these are 3 of the major roles of the pelvic floor, and there are a few smaller ones, but thinking support, sphincter, sexual, those are the 3 biggies. So what does that mean in terms of function? And we've talked about a few of those. So from a sexual standpoint, if the pelvic floor is working well, then typically we don't have dyspareunia or pain with sex. We don't have vulvodynia. so pain in the vulvar region. And in men, having a functioning pelvic floor can help with erectile function. I've already talked about that support role, so the pelvic organ prolapse, pubic symphysis dysfunction, we find this lots in pregnancy, and core instability, which we find across the lifespan. In little kids that have difficulty sitting up tall, sometimes the pelvic floor and diaphragm aren't working well together, all the way until post-pregnancy, let's say, when our abdominal muscles, which have been greatly stretched, and pelvic floor stretch, have some issues. And then last but not least, the sphincter function, making sure that we remain continent of anything, whether it be urine, poop, and all of that good stuff. Okay, and at Blueberry, we treat all of those, which is pretty cool. We spend lots of time talking about peeing, pooping, pain, sex, if you've heard me talk before. Okay, so I want to tell you about one of my most proudest moments as a mom. And that came about last April. Last April, if everybody remembers, we were very much in lockdown, and we were doing a lot of virtual visits with clients, which from a pelvic floor perspective work very well. For the most part, we're able to give lots of good information to people. We are able to help people kind of navigate if their body's not working very well virtually. So I was working exactly as I am here in my kitchen at my breakfast bar. And also my sons were home doing school. And this kind of, I'm bringing this up because I want you, as you're sitting there listening to this presentation now, to think about, when's the first time you ever thought about your pelvic floor? I think honestly for me, it was after I had my son. So I was in my 30s and I was having a few issues. And all of a sudden, as a physio, I realized, I need to do something about this. So flash forward now to March 2020 or April. I'm doing my work here. My 10-year-old son is trying to come up and sit at the breakfast bar. And what he couldn't, because I had all of these pelvises. I had one on one chair, one on the next, one on the next. And he said to me, "Mom, I cannot find a place to sit without sitting on one of your pelvic floors." So here they are, here and here and here. And he had to move one of my pelvic floors to get out of the way. And as a mom, I was so excited that my 10-year-old knew what a pelvic floor was. And that, that sets him up for a different growing up than I had. So thinking about the pelvic floor across the lifespan, this is my cue to you to start talking to your children about it, talking to your mom and your grandma about it, to your grandchildren, because it's a really important thing to discuss as part of your body, and not in a way that is sexualized or anything like that, but just says this is a part of your body that helps with lots of different things. And if it's not working, this is what might be the issue, and that there's lots that we can do, right? So we can normalize the fact that we can help ourselves. Okay, that's it. I'm off my box. What's that called? I'm off my soapbox now. Okay, so if we look, there is a researcher that has done and basically developed a lifespan model of the pelvic floor. And so if we look on this x-axis here, we have the pelvic floor function. And across this axis, we have age. So one of the things that we can see is that depending on what happens, before the age of 20, that our pelvic floor has different level of strength, function, all of that. And through the lifespan, depending on what happens as we age, we definitely see some down regulation of it. And we see that in all our muscles. But if we are high enough on this curve, we don't actually hit the symptom threshold. And that's what this bottom line is. Okay. And we're going to talk about next a bunch of the things that are important as children so that we have a really good functioning pelvic floor as we get into young adolescence. And then we're going to talk a little bit more about what's important through kind of our childbearing years if people have had children, and then what happens later in life. Okay, so it's a lovely model that we can use to really break down what happens across the years. So one of the things that we know is true is that things like our nutrition, our exercise, and child development really do impact how our body functions. And not just our pelvic floor, of course, but all our muscles. And the pelvic floor in particular is a muscle that we start to learn how to control when we hit toilet training. Okay. That's often a period of time that we find that kids develop pelvic floor issues in often it's in constipation or maybe in some urinary incontinence. And the reason is when we teach a child to only go pee or poop on the toilet, what we're teaching them to do is to contract the pelvic floor, to withhold either pee or poop. Okay. And what happens with kids sometimes is they take that kind of to the extreme. We know those kids that hold all day long, they won't go at school. They only like to use the toilet at home to poop, and you have to rush home, or they'll only go in a diaper when you put them in. So, all of that is working that pelvic floor muscle. When that happens, sometimes what we see is that the kids develop some urinary symptoms. So they stop listening to their body a little bit because now they know that they can do this, that they can withhold until the body kind of takes over. So we see that sometimes they leak pee a little bit. Sometimes they have some bedwetting, and we often associate bedwetting with chronic constipation. And other times, these poor little guys have tummy aches lots of the time. They may have a little bit of fecal incontinence or a little bit of skids in their underwear. And what's happening there is they're holding, trying not to go, and a little bit leaks out. And potentially they have been holding for a long time. And what that means is that the bowel and the rectum get nice and backed up. And then the only thing that makes it through are anything that's quite soft, kind of mucousy, because it goes around the larger fecal mass. And this is something that parents will often tell you, the kid has been constipated like crazy. They go in for an x-ray, and what they find is the whole colon is all full, that they have fecal mass in there that they think has been there for a long time. And sometimes these are kids that go a little bit every day, but it's not enough to actually get out the larger amount. So you can imagine the impact of this heavier load on the pelvic floor all the time results sometimes in pelvic floor overactivity. So what are some of the signs of constipation in kids that have already been toilet trained? Urinary frequency, so going a lot, having to go immediately. And you can imagine, if we think about this tiny little pelvis in a 3-year-old or so, if the back is all full, meaning like the rectum is all full, then the bladder gets compressed against the pubic bone. And what that means is that the bladder can't fill very much. And also that the bladder is constantly receiving signals from the pressure of the rectum. So they're feeling that either frequency or urgency. At night, they can't make it through the night. Sometimes they're little daytime pee accidents, sometimes chronic UTIs, because there's more chance of kind of a little bit of cross contamination between the anus and the urethra, and sometimes poop accidents. And sometimes that comes if kids have been on long-term laxatives and really haven't had a solid poop in a long time. So their muscles do get so they can't hold for long periods, and a little bit of poop leaks out. So what are some of the bladder myths in kids? I mean, we hear things like kids should hold their urine to stretch their bladders. This isn't true. In kids, the way that the bladder, which is a muscle, works is by stretching to, about 2 to 300 milliliters and then contracting. So the same way we would do a bicep curl to improve the strength of our bicep muscle, the actual contraction of the bladder is strengthening that bladder muscle. So we do want kids to go about every 2 hours. Um, in order to improve the strength of their bladders when they're little. And that also means that their pelvic floor is not holding a ton that's in the bladder so that the pelvic floor is not becoming overactive. Another myth is that there's only a short window when you need to train your children, so toilet train in this case, and that's not true either. We actually hear from urologists and even pediatric gastroenterologists that sometimes it's better to wait a little while till the child has more brain development before you toilet train, because then they have less chance of becoming chronically constipated. The other thing is, it isn't normal for kids over the age of 5 to experience frequent bedwetting. Once in a while, you're off routine, sure. But if they're experiencing every night, 3 times a week, we should be doing something about this. And better to get on it early than later when the child starts to be kind of frustrated by it. And what do we do as pediatric pelvic physios? So, unlike adults, we don't do an internal assessment unless it's really necessary. It's with parent and child consent, but it's very, very unusual. And instead, what we use is little, almost little like ECG sticky pads that go on either side of the anus. It connects to a biofeedback machine, and by proxy, we can determine how that pelvic floor is both contracting and releasing. And we often see in these kids that the release is more the issue, that they have all this tightness, they're withholding, they have this short, tight muscle, and then a bunch of other things. And then in terms of treatment, we can do lots. We can educate the family. We start tracking what's actually happening. We change some of the behaviors around toilet position, when they're using the toilet, what they're drinking. We definitely always do some exercise recommendation, and then we can move on from there. So, all of this to say, the pelvic floor is impacted by what happens when we are children. Okay. And that's important for both yourself, potentially your children, your grandchildren. Then the next kind of big time where there's pelvic floor impact is in the pre and postnatal period. And we know that pelvic floor weakness or overactivity can cause urinary incontinence, and that pelvic floor muscle retraining is the first line of treatment for all types of incontinence. So this is just a note to say that we know lots happens in both the pre and postnatal period, but that there's lots that can be done. And this is the one area where pelvic health physiotherapists have great research to show that we can not only improve the symptoms of incontinence, but potentially cure. And that cure word comes very, very rarely as a physio, so we're excited when we hear it. So, what happens during birth and even before birth? So, what these curves are showing is what might happen during birth and post birth. So, if we take the first chart, let's follow the curve for lady number A. So, lady number A, they all start quite similar in childhood. So, they had no real pelvic floor issues in childhood. Lady A has a baby and has some impact on the pelvic floor, but rebounds really nicely. And then through the years, her pelvic floor function decreases a little bit so that she has some symptoms, let's say maybe by the age of 70. Lady B is in the middle. And let's say Lady C has quite significant impact on the pelvic floor and doesn't actually recover at all, meaning that she has significant pelvic floor symptoms from early on, from her mid 20s. Okay, so we can help with this repair piece, certainly. And we can, in looking at lots of different factors, help to predict who is going to have some significant injury here. And one of the things which was kind of exciting that they talked about on the conference a couple weekends ago is there is a tool that either midwives, clients, or obstetricians can use that's called Your Choice. It's choice. You can look it up online. And what it does is it really looks at how much pelvic floor dysfunction may happen to a woman if she chooses a vaginal birth or a C-section birth. Okay. And know that we can still have pelvic floor dysfunction after a C-section. But there are some things that they think may be improved with that C-section, especially if it's a very large baby. So on ultrasound, they see very large baby. If they have a shorter mom was one of the things they talked about. And I think that just has to do with the length of our body. And other things, maybe, does the mom have any issues, maybe some connective tissue issues, even in well before she became pregnant. And then they look at that combination of things, and you can actually put in your information, how old you are, number of births you've had, any kind of issues you had before, and it will kind of predict what might happen in this pregnancy. And it's an interesting way to look at things and to be informed. We also know that the different interventions that they do in labor can predict how our pelvic floor does. So, one of the things that we know can impact pelvic floor function in the postnatal period is if they use forceps or vacuum. So, any kind of instrumentation has a little bit more chance of causing pelvic floor injury. So, the conversation that they had during the conference between surgeons was we really need to do good education with our residents, um, to make them aware that they need to take care of not just baby but mom in the labor. So trying to do as much as we can to encourage a birth without instruments, provided mom and baby are going to be well at the end of the day. And then mechanism of injury, we know that we can actually change sometimes how much injury happens to the pelvic floor by allowing the mom to move in labor. So there's good evidence to show that when women are allowed to choose their position, that helps to decrease pain, sometimes to decrease the length of the labor itself, and in doing so can reduce how much injury happens to the pelvic floor. So there are things that we could do and figure out even before the labor happens. And there are things that need to happen during the labor. And then, of course, in the postnatal period, we have lots of good and helpful tips for people to build back their pelvic floor strength, so that now, if we look at the bottom, here is a woman who had one baby and bounced back, and then another woman who had two and did pretty well, but you can see she didn't come back quite up to the level of this woman A. So, I mean, what we want to see ideally is when you come out of that birth and delivery, that you come back to the regular curve that you would be on. So, in the pre and postnatal period, there's lots of education we can do. And one of the things that was exciting to me was to hear this. So they did a Cochrane review, and a Cochrane review is just a review of a lot of different literature, and they condense it and determine some really good recommendations. And in this Cochrane review, one of the things that they found was that if women, even before 10 weeks pregnant, know how to activate their pelvic floor, release their pelvic floor, and have good pelvic floor function, that they are women that stay continent well into the late stage of pregnancy and have a better chance of preventing incontinence in the postnatal period. So that's good news to us. Anything that we can do to prevent injury is what we like to be able to do. And so what I've shown here is just a couple of the things. I mean, we know when we're trying to activate our pelvic floor, we do some lying exercises. We proceed to doing exercises in seated and then standing, because that helps to increase the difficulty level for the pelvic floor, because that pelvic floor is a anti-gravity muscle, and as soon as we're in a standing or seated position, it works harder. And then we also talk about different ways of activating the pelvic floor, a little homage to blueberry therapy. So one of the things and cues that we often use is pull a blueberry up and in, and that's hence the name of the clinic. So just trying to get people to understand where the pelvic floor is, how it works the best, well before they're actually even showing in pregnancy, has been shown to be quite effective. The other bit of literature that I didn't include in here, but we are seeing that education about perineal massage. So massage of the perineal area, so that area between the vaginal opening and the rectal opening, we teach women that about 33, 34 weeks into pregnancy, and we teach it to try and get them to understand how to lengthen the muscles, lengthen the connective tissue. And for years, we said, this is a good thing to do, but the research isn't really profound. But we actually have some much better research now that shows that when women are able to do that and able to feel how their body can release and relax, that it shortens the active stage of labor by like an hour and 37 minutes. So a little bit of work goes a long way. And that's exciting to us too. So if have a quick drink here. If women end up with some weakness in the pelvic floor in the postpartum period, this is kind of what it looks like, right? So if we look on the diagram on the left, here's our bladder full of urine, but we have a nice strong pelvic floor that's keeping urethral closure. On the second one, if this pelvic floor muscle is starting to drop down a little bit, it isn't quite as sturdy looking as this one, then instead of holding all this urine, what we can see is that the pelvic floor allows this urethra open a little bit, and we leak a little bit. So that's what we're talking about when we're talking about symptom threshold. So we want people to be able to recover well in the postpartum period and maintain their strength so they don't reach the threshold when they are starting to notice leaking of urine. And if we look back at some guidelines done by the European Urologists, Association of Urologists, what we're seeing really makes sense is that offering supervised pelvic floor muscle training lasting at least 3 months as a first-line therapy to all women with stress urinary incontinence, that's the cough, jump, leak incontinence, or mixed urinary incontinence. That's a combination of stress and urge incontinence, that where you can't pass a bathroom without having to go. And that's really important across the lifespan here, including elderly and postnatal. And even offering programs that are as intensive as possible. So one of the things that we know is that lots of people understand that pelvic floor training is important. They understand that they need to do their Kegels, but what does that mean? What does it feel like? What's the intensity? All of those things are really hard to sort out on your own. And in coming to see a pelvic physio, that's one of the things we do really well, is show you how that muscle contracts, what's your best contraction, how you need to challenge that muscle. So it's like a personal trainer for your pelvic floor. Okay, so what we've talked about kind of to date in this lifespan model are those predisposing factors for pelvic floor dysfunction, and that's like your childhood growth, nutrition, development. We've talked about intervening or inciting factors, which are your pregnancies, what happens after pregnancy. And now we're going to move on to intervening. So that's more as we age. And recognize that we see women who have pelvic floor dysfunction who have never had children. So don't let me skew you to think that, that's the thing that might cause an issue. It is one of the things, but there are others. So we do know that there are variations in normal aging, whether you have potentially a neuromuscular condition, you might have MS or Parkinson's or a connective tissue disorder. But we do also know that on the whole, as we age, that our muscle strength goes down a little bit. And these are the things that we want to kind of think about as we age and age well. There are people that have had issues with the pelvic floor because of stressors. And those stressors might be that they have a job where they're having to do lifting all the time and they're putting lots of load through the pelvic floor. Maybe they have a condition like COPD or asthma where they're really coughing a lot and creating that pressure. Or they've had some constipation through the years, and that has created a pelvic floor that has some issues. And then factors that lead to weakening. People who have been on longer term steroid use, which can cause issues in muscle and disease atrophy. So we're back to this little graph again. So we've already talked about these predisposing, potentially these inciting factors. So this might be a pregnancy. This might also be, a pelvic injury. I have a client who was in a very bad car accident and had 3 fractures of her pelvis. And so that certainly could be an inciting factor. And then we have these intervening factors. And these intervening factors, I want you to recognize, could be like this, but they could also be like this, where you start to actually focus on the pelvic floor and take yourself onto a much better curve, meaning that you're going to have less symptoms, potentially no symptoms. And if you do, they may be less severe and impactful on your life. So one of the things that we do see, though, is that through the years, as the pelvic floor is exposed to pressure for many different reasons. So it could be age, it could be that you've had many children, all these things we talked about before, chronic coughing, bowel dysfunction, as well as estrogen deficiency. And that estrogen deficiency happens in the postnatal period. It happens in the postmenopausal period. All of those things impact the ability for the pelvic floor to contract, and also for it to be really that nice support at the bottom of the pelvis. And we know that about 50% of women have some degree of pelvic organ prolapse after one baby. That may not be enough for them even to understand that it's there, but it definitely does happen. And we see as women age, I believe the stat is that something like 10% of women will have some type of surgery to help repair pelvic organ prolapse. So it's a pretty large percentage of people that experience it, not necessarily that go on to need lots of intervention, but quite a few of us have some degree. So if you haven't seen these before, the bladder is supposed to sit up nice and tall like this one. So what this is showing is the rectum at the back, the uterus and vaginal canal, the pelvic floor running underneath. And what's happening is the bladder is tipping down and back and bumping into the front of the vaginal wall. And we would call this bladder prolapse. Okay, prolapse simply just means dropping down. In this case, we're seeing that the bladder looks great, uterus looks great, but the rectum is dropping down and causing this bump into the posterior or the back aspect of the vaginal wall. So rectal prolapse. And last but not least, we can see that the uterus has slid down in position. And lots of times, and this shows it quite nicely, when the uterus, which is a little bit more dense in terms of structure, When it comes down, we also pull a little of the rectum and a little of the bladder with it. So all of these, if you are investigating your own body, um, the bladder and the rectum feel and look almost um, like a balloon and can be palpated and kind of they're a bit softer. If someone has uterine prolapse, often this piece of the uterus and the cervix feel much more dense in terms of tissue. Okay. So first line of defense for prolapse is pelvic floor strengthening. And we see that not only can we help improve the symptoms of prolapse, but there is some research to say that we can help reduce the prolapse by a little bit. So we grade prolapse on a 4-point grading, and there is some research to show that we might be able to get that prolapse back up a grade. So here's where I chatted about how hormones and hormone function impacts the pelvic floor. Once the estrogen levels go down, and so most women start going into perimenopause anywhere after about 35. We start to see that our estrogen slowly goes down, and then average age of menopause is 52. And at that point, when our estrogen levels go down, we see that there is a little bit less integrity of the pelvic floor. So we might see people that have done really well across the lifespan, but as they get closer to menopause, and menopause itself is 1 year with no period. So menopause itself is 1 day in time. We're perimenopausal for a long time and we're postmenopausal for a long time, but we're only ever actually in menopause for just that 1 day where we haven't had a period. So once we get into postmenopause and our estrogen levels are lower, we can see the pelvic floor sometimes isn't functioning as well, but that doesn't mean that we can't strengthen it. It doesn't mean we can't improve the function and give you some good tips to make sure it works better. So it's not too late. It's just one of the things that impact it. And then last but not least, I'll just talk a little bit in the women of older age is when we often see a little bit of overactive bladder syndrome. Okay. Um, it's a group of symptoms that often are associated with sudden urge. For some women, they leak a little bit of urine and some they don't. So sometimes we call it overactive bladder dry, and sometimes we call it overactive bladder wet. But it doesn't only impact women, it can impact men as well. And one of the things that we see is it's really impactful because you start changing your routines. You don't want to be out of the house for too long because you're going to need to use the bathroom. You can't go on a long car ride when times were normal. Can't sit through a full movie in a movie theater. All of these, and it can impact sleep because people are getting up at night lots because of this. So this is one of the things we see that happens in terms of symptoms with the pelvic floor. On the left, what we see is a normal bladder full of urine and everything is great. It's not. So what happens when we actually have to go pee is the bladder contracts, and it contracts only when we're sitting on the toilet. That's how things should happen. What happens in an overactive bladder is even before that bladder is filled all the way, the bladder muscle starts contracting. That's that sense of, oh my goodness, I gotta go and I gotta go quick. That's your bladder contracting. And we see that happen. At the same time, we see lots of people that have overactive pelvic floors. And so when we see clients like that, we're working on some behavioral modifications to reduce that bladder contracting when it shouldn't. And we also are coaching people to help to lengthen their pelvic floor, because as that pelvic floor kind of rides up and there's lots of tension, it can cause more sensations to the bladder, making it contract more. So I'm going to just fly through this so that we have time for some questions. As I mentioned, with overactive bladder, we do lots of teaching around things that we could be intaking that don't cause issues. So we know that caffeinated, carbonated, alcoholic, and stuff with lots of citrus can cause bladder irritation and increase the symptoms of overactive bladder. So these are things that we coach people on how to either reduce or change or just even introduce more water. We work on lengthening the pelvic floor and then strengthening it, and on some urge management strategies. Okay, so overactive bladder is the combination of lots of things. And it's one of those symptoms that we see later as often later in the lifespan. So at this point, I've gone through my formal slides, but I would be very happy to answer any questions that people have. And I will, and as I mentioned, if people have additional questions or would like to reach out after the fact, please don't hesitate to call us, to email us, and check out our website. We've got all kinds of great blogs and information on there on a variety of different things, geared at women, men, kids, all kinds of good stuff. All right. Do people have questions, or you're welcome to put it into the chat. Good. Well, thank you very much, people that were able to join but have to leave. I absolutely understand, and it's always great. We have great turnout for these, and it's really nice to be able to connect with all of you. A question here: can you speak a bit more to a bit more information about connective tissue complications or examples of this? Yes. So certainly in terms of connective tissue, I'm not 100% sure what you're referring to, but what we think of is when it comes to pelvic organ prolapse, one of the things that helps support the pelvic floor is helps support the pelvic organs is the pelvic floor. That muscle can be strengthened. But what also happens in prolapse is as the organs kind of reorient a little bit. So, again, if we have bladder, uterus, and rectum here, and we're talking, let's say, of bladder prolapse, the bladder is rolling down into the front wall of the vagina. Some of that movement is due to changes in connective tissue. So in some of our ligaments, in some of our fascia, and some of that is as a result of potentially a birth. It might also be the result of a woman who has a connective tissue disorder, so that they don't have kind of the same amount of elastin and collagen as other people. So at the same time as we're working on pelvic floor function to help support pelvic organ prolapse, we may be encouraging women to use something that helps support the pelvic organs, like a pessary. So I've talked about those in other talks, but a pessary essentially is a support for the vaginal canal. So if we see really profound changes in vaginal structure, because that's that soft tissue, a pessary can help maintain the structure of the vaginal canal so that the pelvic organs can't fall. It's like if you had a house built and the walls were starting to not work as well, and you put a nice support beam across, then you're going to keep your roof on. And that's kind of what a pessary does for the vaginal canal. I just thought of that one now. I hope that answers your question. If it doesn't, I'm very happy to answer in other ways. I see there's another question here. Pelvic floor issues for teenage boys, men, from years of holding or other issues. Okay, well, I'll get to this. What are some of the signs, symptoms that they have issues, and some of the exercises, treatment that can be done to help? Okay, yes. So first, if boys or girls are holding, and so right away we can see those little kids. Those are the little kids that go behind the couch, don't want to poop in front of you, that are squeezing to get and or are tiptoeing around to try and prevent having either a bowel movement or peeing. So we can see it as they're little. And as they get older, some of these kids are kids that potentially, it kind of goes one of two ways. They're kids that barely go at all. Okay, so they wait really long periods and then sometimes have a little bit of urinary incontinence because they have overflow incontinence, or they're kids that go really, really frequently because um, there's so much built up in the rectum because they're not wanting to go, that the bladder has very little room to actually expand. So those are some of the things that we see. And then as they age, so if we're thinking about boys, and we haven't talked very much about boys and men, but we see boys and men who have testicular pain, have rectal pain, have tailbone pain, have pain in the perineum. And if you can imagine, this muscle being really stretched for a lot of the time, and then also trying to help support this weight, which is the poop, all the time, then sometimes the muscle, it gets fatigued, it gets tired, and it tells us that it's really not happy by pain. And then as they get a little bit older, we can see potentially that they have issues maintaining an erection. And I've had a few first, second year university male students who, kudos to them, went and talked to a urologist, and had an issue where they could only maintain an erection, let's say, for 30 seconds. So that can be where, the muscle is so stretched that it's not actually able to do a very good contraction when it's needed. And part of what an erection is that the pelvic floor muscles contract to maintain the blood in the erectile tissue in the penis so that you can maintain that erection. So we do lots of education on lengthening exercises of the pelvic floor, how to accurately contract the pelvic floor, and then build back their both strength and endurance. So those are kind of the signs of withholding. The output of that might be pain. It also might be issues with erectile function. And as a mom, having those great conversations with your kids, not easy, but good conversations to have too. I hope that answers your question. And some of the treatments that we talked about, really doing some good lengthening, having good conversations with your kids about listening to their body. If their body is telling them that they need to poop, they really should go. If their body is telling them that they need to pee, also they should go, and not trying to force them to go all the time too. So as you leave the house, just go just in case. That's one thing that we try and get parents not to do with their kids, unless they're that kid that really holds for long periods of time. All right. Is waking up at night to have a pee up to 3 times a night considered an overactive bladder? Yes, to be honest, it is. What we say is it's really normal for people over the age of 40 to get up about once. But beyond that, what it means is that that bladder is not able to hold very long, or is really a bit hypersensitive. So it's giving you that sense of urge before you actually need it to. So one of the things that we would look at is how often are you going through the day? Because if we can clean up the daytime voiding pattern, then usually the evening comes along. And if we see that, you're going quite frequently during the day, that means the bladder's not expanding that much. And then when we're asking it to go 8, 9, 10 hours overnight, if you're getting a good night's sleep, then it's really hard for it to do so. So we look at the daytime to try and clean up the night, and that usually does the job. I mentioned unwanted escaping gas. How do you strengthen the pelvic floor for that? So great question. A number of years ago, I had a fantastic woman come in. She was in her like early 70s. And I always ask people, if you had a fabulous result in coming to see me, what would that look like? She said, I just don't want to be the fart grandma anymore. And I love that because she was really upfront. And so I'd like to challenge the myth that it is always weakness that causes us to lose urine, to lose poop, to lose gas, because sometimes it's just that the pelvic floor has this resting level of tension or overactivity, and it won't contract when we need it to, that causes us to leak urine, to leak gas, that kind of thing. So one of the things that myself or any one of my amazing physios at Blueberry would do is do a really good assessment to determine, is it overactivity and we need to kind of work on that, or is it truly weakness where we need to strengthen? And then if it is weakness, then we do similar strengthening as we would for kind of more the front of the pelvic floor for urinary incontinence. So we might challenge you to do some strengthening in a standing position. We might add in weights. We might add in a bit of pressure down, either through a jump, through position change, and some really targeted exercises that way. Another question, what is, or is there a correlation between pelvic floor function and decreased sensation sensitivity during sex? That is a great question. Give me a second. I'm so glad somebody decided to talk about sex. It's like my favorite topic. So yes. So what we know is that a lot of people have a very decreased concept of actually what's down there, right? And especially after something like potentially a pregnancy, but not necessarily. And so one of the things we find is as soon as we start working with people and trying to get them to understand how to both lengthen and contract their pelvic floor, that then they have an enlarged brain map of the area. So if you can do a good pelvic floor contraction, you can contract part way, then all the way. You can contract quickly, slowly. You can contract in a diagonal. That means you have a really good concept of what all is down there. And then what we find sometimes is people have greater sensitivity and greater feeling, and sometimes better pleasure. So I've had a few clients that used a biofeedback machine. I don't actually have one here. I have some good stuff in my house, and when somebody comes into my kitchen, they laugh because I have this. Charlene Loudon, who I love and work with, got me this a few years ago. So you can see it has like all kinds of good stuff, and it just sits on my kitchen counter. I want my two boys to be the best educated boys around and make really good girlfriends, make really good boyfriends. That's what I'm hopeful for. Anyway, back to the question. So I've had people use a biofeedback machine. That machine works like a grip strength measure. So there's a little piece that goes in the vaginal canal. You contract your pelvic floor, and then on an app on your phone, it shows you how much you're contracting or not, and how much you're releasing. And the result of that for some people they've said, I did this to do pelvic floor strengthening, but what I found was I had more pleasure during intimacy, whether it's with yourself or with your partner or what have you. So that's a very good question. Thank you for typing it in there. It's getting close to 9, but I'm willing to take more questions if people have them. No? Okay. Well, thank you very much, everyone, for attending and for asking those great questions. Again, if you have more or want to connect, certainly go to our website or email blueberrytherapy@gmail.com. And I hope everybody has a great night and look for more workshops. We're going to having a bunch more in April. Thank you, guys.